Good afternoon, everyone, and welcome to our Patient Involvement and Care Equity Day, Day 2 of Clinical Audit Awareness Week. Thank you so much for joining us in this very hot afternoon. My clock says it's 2 o'clock and that it's 32 degrees here in North London. So I hope you're all keeping cool and have a glass of water next to you. So I don't want to talk too long because we really want to get ahead and talk to our speaker, hear from our speakers. So, Catherine, please could you move to the next slide so we can look at our agenda for the afternoon. Next slide. Well, as Catherine tries to find it, she's trying to put our agenda up. But what we're going to do, we're going to hear from the National Maternity and Perinatal Audit. We have George Dunn here as our project lead for that programme, and he is with Sarah Fisher, who is a women's health advocate and a member of the Women and Families Involvement Group, and they're going to talk about the impact of the work of that group on the audit. Really pleased to welcome Wendy Olayiwola, who is the National Maternity Lead for Equality at NHS England. There you go, Catherine, you can see the slides, thank you. And then after that, we will be having panel discussion. And joining those speakers, we have Nicky Vousden, who is an MBRRACE-UK representative. So those who don't know, MBRRACE is Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries, one of our programmes within the HQIP. And we also have Meg Hill, Riham Lotfi, Naomi Rose and Al Richards, who are members of our service user network and parents and experts by experience. So really looking forward to a panel, great questions that we've already got together, but we'd really like to hear from you. So please use the Q&A function that you can see at the top of your screen to put your questions forward to those panel members. Okay, so housekeeping. So please to the next slide. All microphones are auto-muted, you'll see, and that's to avoid any background noise. You can put your cameras on if you'd like, but please feel free to switch them off if you prefer. The chat function has been turned off for this event because we're using that Q&A function. So please see that box on the top, and you should be able to put your questions in there for all of our speakers and panel members. If you can't use that, we've been told that it's best to use a laptop or PC and the browser version of Teams, not the app, to get that full Teams webinar experience. But if you still can't do it, you can go into the contact us form, which is on our website. Should we experience any technical issues, which I really hope we don't, and the webinar ends earlier than expected, please wait around 30 seconds and then rejoin either by clicking the rejoin button on your screen or via the original joining link. Finally, we encourage everyone to share this event and any activities that you're running in your organisation up and down the country during Clinical Audit Awareness Week. So use social media and use the hashtag CAAW26. So together we want to shine a light on the importance of evidence-based healthcare improvement this week. Now, I'm not sure if I introduced myself, and I keep doing that. So I'm Kim Rizal, and I'm the head of Patient and Carer Engagement at HQIP, Healthcare Quality Improvement Partnership, and we are running this event today. I think that's enough for me because we really want to hear from our speakers. So firstly to George. George is the project lead for the National Maternity and Perinatal Audit since 2019, which is a really long time, George. And you previously worked on the stroke audit, so you've been involved for a long time. And Sarah Fisher, who's a member of the Women and Families Involvement Group and an experienced women's health advisor, and she's involved in many other maternity projects previously with NIHR and this institute. So we're going to hear from them now. Over to you, please, George.
Brilliant. Thank you so much for inviting us to this. If we'll move on to my first slide. Perfect. And then, yeah, straight on to the next slide. Thank you so much. So I'm going to start off just by giving you a very quick summary of some of the key achievements of the NMPA's Women and Families Involvement Group, what they do and how they've made an impact on the audit before handing over to Sarah, who will give you a much more insightful view of how it is to be a member of that group and some of the work that we've done. So just a brief summary of the group. We meet 3 to 4 times a year as standing meetings online, but when other work comes up, we are always quick to organise a meeting with those who we need to have individual meetings as topics arrive. We have about 10 members. We try to get as broad an experience as possible in terms of geography, in birth experiences, things like this. Obviously, 10 members means we can't, get the full population experience, but we try our best to get a good breadth of experience. And we are soon going to be recruiting for a new batch of Women and Families Involvement Group members, as we like to try and keep the experience relatively recent as well and get that balance right of experience and recent experience and time on the group. So the group doesn't just review our outputs, but they're really a core part of deciding everything we do in the audit. So whenever we're coming to decide new topics, new things to do, new data to collect, this group is always at the core of that, deciding of what we should do next and the direction of the audit. And obviously they're really important too in disseminating the work of what we do and making sure it gets in front of those who need it. Next slide, please. So just an example of some of the big changes that our group have made. If you use your eagle eye there, you may see in these 2 examples of our reports. In our 2017 report, you have 95 pages to go through there, full of very, very valuable clinical interpretation, but a bit of an intimidating thing to come across if you're wanting to learn what the NMPA is all about and what data can be used to help you, whoever you are, whether you're a clinician, someone looking to use maternity services, or anyone in between. And now, of our most recent report that was published earlier this year, is last year, sorry, is just that 12 pages. And our Women and Families group were a huge part of boiling down this report into something really accessible and usable by people. They previously helped us produce lay summaries, but actually through the work we realized boiling this down into something that's approachable and accessible is actually best for the vast majority of people who are reading this report. We obviously still have all of the important clinical interpretation we have in there, all of getting into the weeds of the statistics. We still have that in additional outputs, but this is what we put in front of people. And I think the Women and Families group really advocated for this and helped us design this new way of disseminating our results of the audit. Next slide, please. And this is something as well that was produced as part of this. So these are our results at a glance page, our infographics in the report. And we have quite a lot of measures, quite a lot of complex data to share as part of our reports. And getting this down to 2 pages was something we went through a lot with our Women and Families Involvement Group. But I think it's something that we've really succeeded in. Just 2 pages in a report, having all of the key results of our key indicators there in an accessible way has really helped anyone using NMPA data to really get a grasp of what our reports are trying to say. Next slide, please. And another big achievement of the Women and Families group of the audit is this family gateway area. It actually came from the Women and Families Involvement Group themselves. They decided they wanted to produce an area of our website that was devoted solely to people looking to use maternity services. And we co-produced this animation with them. I'm not going to go through the technical ordeal of showing you this animation now, but on our website, if you look in the what is the NMPA page or the Family Gateway page, you'll see this 2-minute animation describing in really simple terms, probably better than I could in this meeting, what the NMPA is and what we do. And it's all because of the Women and Families group. They decided to produce this and make sure that we have an area of our website devoted to people who might want to use maternity services and show how the NMPA can help them. And next slide, please. So finally, on some of just the big achievements of this group and how they've made our reports more accessible and usable for all sorts of people in healthcare. Just a few pieces of feedback that's always really reassuring to receive from both members of the Women and Families Involvement Group, but other individual groups who've helped us as part of that process. So I think a couple of these quotes are from the group Big Birthers, who helped us with a specific report on BMI in maternity care. It's just really positive to see like lay users' voice getting involved in the audit, being seen in our outputs and then having feedback of that process as well. But better than a quote, I can hand you over to Sarah Fisher, who's a current member of the Women and Families Involvement Group, to tell you a bit more.
Thanks, George, and hi, everyone. So to tell you a little bit about myself, I joined the NMPA Women and Families Group 4 years ago. Passionate about women's health and evidence-based information to support patient-centred care and choices, I was really excited to contribute to the group, bringing my lived experiences of maternity care and perinatal mental health issues as an autistic mother of 3. When I became pregnant with what I planned to be my second and final child, it was a bit of a shock, to say the least, to find out that I was pregnant with twins. When seeking to make decisions during my twin pregnancy about where and how to give birth, I was dismayed by the limited data and information on risks and outcomes relating to multiple birth. Oh, sorry, I've just realised I've forgot my first slide. Sorry, thank you. There we go. That's me and my 3. Okay. Yeah, so it was really disappointing and worrying for me to be wanting to access information about outcomes and how to help me decide how and where to give birth, etc. But to see that there was so little information and data relating specifically to multiple birth, and researching and advocating for the choices which I felt were right for me really wasn't easy, but I was also conscious that others face additional barriers and inequalities and have less autonomy. So this was all part of my motivation to join the audit. Have my next slide, please. As a Women and Families Group member, I've contributed and helped bring patient and public perspectives in many different ways, including those mentioned by George and more. But I wanted to focus on what I'm most proud of, which is my contribution to increased focus on multiple birth data and related outcomes for mothers, twins and triplets. There are various health inequalities associated with multiple pregnancy and birth due to the increased risks of complications and poor outcomes. I've listed just some of these on this slide. And there's, sorry, back to that slide. I just mentioned slide and say next slide, thanks. Yeah, so these are just some of the various health inequalities faced by women and birthing people pregnant with twins and triplets and their babies. And there's some evidence of widening inequalities in stillbirth and neonatal deaths between single and multiple births. Next slide, please. Yeah, multiple birth data collection is complex and inadequate. And it's been enjoyable, but also frustrating to learn more and more about that. So vital data needed about multiples can be missing or recorded erroneously and inconsistently. This includes like the type of multiple pregnancy relating to the different arrangements of placentas and amniotic sacs, as well as the number of babies, the order they were born in, and correct labelling or not. These data inadequacies in turn exacerbate the health inequalities between singleton and multiple pregnancies by undermining research and learning. Next slide, please. So how have I helped address this as part of the NMPA? Well, it's been an honour to represent families and multiples, providing a consistent voice advocating for multiple birth within the audit. As well as participating in the Women and Families Group, I've been part of clinical reference group meetings, inputting into selection of clinical measures and help prioritise topics important to families. And through my networks and link to multiple birth charities and clinical researchers, I've fostered wider public involvement and input, which has resulted in collaboration to help improve and standardise multiple birth data collection, including through maternity services dataset updates. So a big thank you goes to Twins Trust there and Elizabeth Bryan Multiple Birth Centre for all their contributions and support with this, including technical input that I don't have. Next slide, please. Yeah, thanks. But the biggest and most recent achievement has been the publication this year of a snapshot audit examining multiple birth outcomes. Using NHS birth data from England, Scotland and Wales in 2023, the purposes of this report was to assess if measures reported for single births in the NMPA annual clinical report can be presented for multiple births. So I'm proud that this report paves the way for multiple birth data to be included in NMPA's future annual reports, as well as making important recommendations to make wider improvements to multiple birth data collection. Ways I contributed to the report include collaborating with Twins Trust and the Elizabeth Bryan Multiple Birth Centre to provide feedback on the draft, inputting into the selections of family-friendly images and photos, and suggesting explanations, statistics and plain English changes to wording for the benefit of lay audiences. The impact of my involvement and other patient voices from the family group has been a report and wider NMPA resources that, as George showed, are clearer, more relevant and accessible for the public as well as professional audiences. By consistently and meaningfully involving families, NMPA has made the audit more inclusive, better reflecting the diverse needs and experiences of women, birthing people and families, and with greater potential to address health inequalities. Thank you.
Thank you so much. That's brilliant. I'd love to seeing these pictures, and thank you for sharing your pictures, Sarah. Beautiful family. I really think we can see the impact of your involvement here, so that's great. What we're going to do is going to go straight into Wendy's presentation, and if you can put your Q&A into that Q&A box, we will come back to questions for George and Sarah after we hear from Wendy. So pleased to have Wendy Olayiwola with us today. She's the Maternity Lead for Equality at NHS England, but also a registered nurse and a practicing midwife. And she's going to talk about some of the data around maternal death and the action the NHS is taking to improve equity. So probably just a quick sensitive warning, just in case for people that might not be wanting to hear about maternal death. But Wendy, over to you.
Thank you very much. Hope you can hear me okay there.
Yes, we can hear you.
Lovely. And thank you for inviting me. And thank you to George and Sarah for that fantastic presentation. And next slide, please. And next slide. So the next couple of minutes, I will be taking you through why this matters, why we're talking about inequalities within maternity care, maternity and neonatal care, and what are the data telling us, the strategic context of what we are trying to do in addressing maternity and neonatal disparities, and also the actions that the NHS is currently taking to improve the experiences of those that are going through the disparities, and also the action that we're taking to also support the workforce. And I will then summarize. Next slide, please. So why does this matter? Why are we talking about it in 2026? We know that outcomes in maternity care are not equal. We have enough data and evidence to inform those beliefs. Women from Black, Asian, and deprived backgrounds continue to experience poorer outcomes, including higher rates of maternal morbidity and mortality. And we know these inequalities are preventable. We know they are rooted in the system. Also, it is also structural and cultural factors within the healthcare. So it is important that we start the conversation to ensure that both women and their babies have the same care across our services. Next slide, please. So the next slide is really about data, and I will try and break it down so that people can truly understand it. And it's absolutely self-explanatory as well. And many of this data, there isn't anything new. Many of us on the call would have seen, the MBRRACE report year in, year out. MBRRACE have been reporting for a good number of decades now, informing us about disparity and the experiences of some communities within our services. And also, in addition to MBRRACE report, it's also the lived experiences of those communities, our Black and Brown mothers using our services. So you would have heard about 5 times more, the birthright report, informing us about the lived experiences of those communities. So currently, and it is important to say here that we are seeing the improvement in the data, because about 5 years ago, when 5 times more was actually started the campaign, it was 5 times more, and that's why they're called 5 times more. So this slide really showed that it's now 3 times more for Black mothers. So this is the most recent January 2026 from MBRRACE report, that the mortality rate for women from Black ethnic groups, is still, for 2022-2024, is 3 times more likely than the white mothers. And for the Asian mothers, it is 15.14, which is obviously not as significant compared to other previous data. So it's about 1.8 times more for Black brown mothers to die within our services. Next slide, please. And the next slide, just again, it's not just about ethnicity, it's not just about the race in terms of the experiences of our women and their babies. It's also about, where they live, about the postcode, deprivation. So for those that are living in the most deprived areas, it is twice more likely for them, again, to die within our services. So if you look at those that are living, the slides really show different, it shows different ethnic groups. And you can see that for those that are living more in the most deprived areas are more likely. And also in deprived areas are also different ethnic groups. And it's more likely for, again, Black and brown mothers to die within those socio-economical sector. Next slide, please. And this shows, the next slide shows us about the babies. Again, the inequalities based on ethnicity and deprivations of babies in terms of stillbirth and neonatal death. So the stillbirth and neonatal death mortality rate is around twice for Black babies and 60% higher for Asian babies. And when you look at on your right-hand side, for the death, for those that are living in the most deprived areas, again, it's much more higher for their babies to end up in stillbirth or neonatal death. Next slide, please. This slide, it's the most recent slide from MBRRACE UK that was published a few weeks ago, actually. This was published. Again, we are seeing overall the mortality rates have fallen by 21% over the last 10 years in the UK, and that's such a good news. It is important to flag what we are doing well and how the data are actually improving year in, year out. But it is not necessarily improving for those of Black and Black communities. Next slide, please. So there is a case for change in terms of different ethnic groups. And this slide showed us the congenital anomalies, which obviously account for the most neonatal death, and especially specifically for Pakistani babies. However, this data for this year has also seen a bit of improvement for those babies. And I must really say that there had been a lot of work within those communities to improve the care of their babies. So you can see that in England, the anomalies contribute usually to 77% of stillbirth and 35% of neonatal deaths. So congenital anomalies occur in 6% of births to first cousin couples within that community. And it is really absolutely, placed for us to see that improvement within those communities. Next slide, please. And we do know that this is the biggest single change between 2 years of any ethnicity for these particular groups. Again, the stillbirth and neonatal death rate with ethnicity on this slide has broken it down into, if you look on the left-hand side, the stillbirth rate for Black babies is still much higher compared, with the white babies or the Asian babies. And on the left-hand side is stillbirth, apologies, and the neonatal deaths on the right-hand side. You can see the Asian babies, in terms of the death rate for Pakistani babies, we are seeing the dropping from 3.6 to 2.5 based on the most recent MBRRACE report. And the Asian baby for the Indian is absolutely rising up, and the Black babies is kind of, stagnant in that sense, which is actually good, because previously we are seeing the rise amongst the Black babies. Next slide, please. So what is it that we are doing with all this data, with all this information that we have? So the strategic context is what I'm just going to take you through in a minute. We do know that the government of the day is absolutely committed to address the inequalities within maternity and neonatal system, and they really set an explicit target to close the Black and Asian maternal mortality gap. And there have been a lot of conversations around that, as well as interventions that the next slides I'll be showing you through the next slides. An announcement is also hopefully will be made to also look at addressing both the preconception health as well as the social determinant of health, as we know that it's not just only about the clinical issues or clinical factors that that contribute to these disparities. There are also socio-economical issues. In terms of what the NHS England have done, the NHS CEO and the CNO, asked all the chief nursing officer as well as the chief executive officer to actually make maternity inequalities a priority, especially when it comes to racism and discrimination within the services. And that letter went out sometimes this year. And again, we can see the ripple effect of what that letter is. Every trust is now making that as a priority, and is now being discussed at every board level. The National Maternity Investigation, which many of you will be aware of, which is being chaired by Baroness Amos. Baroness Amos, we are hoping to receive a final report by the end of this month. Previously, she gave a reflection of this investigation when it was started 2025 in December, and then an interim report came, earlier this year, obviously highlighting a lot of inequalities within the services, including racism and discrimination. And following that is a National Maternity and Neonatal Task Force also has been set up to address every recommendation that will be coming from that investigation. Next slide, please. So actions that we have really taken from NHS England. Many of you on the call may be familiar with the equity and equality guidance that was published back in 2021. And that was the local maternity and neonatal system equity and equality guidance, which really asked the LMNS, the local maternity and neonatal system at the time, to look at the population, to understand their demographics, to understand the population that they serve, and to also understand the challenges, that, of course, within those populations. As we know, regions differs with challenges, and also which is very much dependent upon the different population. So based on that, guidance, the LMNS was also asked to develop an action plan, which was published in 2024. So each LMNS is across the country have published the action plans, and they're working through the implementation. In addition to that is also, we have the 16 equity and equality interventions that have been developed. And out of that are 6 priorities that we're taking forward as an organization and supporting the services. Looking at the equity and equality data dashboard was developed in January, and that has been rolled out, and is so really humble to see many trusts engaging with that, so that this will give us a much clearer understanding of what the data is at local level. Maternity triage principles and measurement was also published in January of 2026, and also looking at going back to the education system and getting it right, even right from our trainees, and that toolkit is also being developed to support the educators. And also, in addition to that, is our planning guidance for 25-26, supporting and asking the ICBs and providers to continue to address variation in access, experiences, and outcomes of their population. Next slide, please. I think it is very important to mention it here that with all these actions and interventions that is being put in place, workforce is really central in this, to be able for the workforce to be able to support, the women and babies and the population that they serve. And we're very much aware of that. Currently, NHS England perinatal equity anti-discriminatory program is being rolled out across the country to support our senior leadership teams and clinical leaders, especially those that write the policies, to ensure we tackle racism and discrimination through the policies and those structural, challenges that we currently have. And the plan is for this to be rolled out from October 2025, which we are currently seeing being rolled out up until 2027. And also the national programs for the workforce are also being rolled out, and some of them, the Changing and Growing Together, which is the reverse mentoring. I've seen a good number of professional groups taking them down through that program to ensure it's very much a relational program to identify the challenges that each workforce from different backgrounds do face, which obviously have improved their confidence in addressing, racism and discrimination, as well as, the workforce challenges. There is a link between the experiences of Black and our brown community, the mothers that uses our services, and the experiences of our Black and brown staff. So for us, it is important that that is actually addressed, so that the workforce that is experiencing racism and discrimination is addressed, as well as supporting them to provide culturally sensitive care. So the cultural competence and safety e-learning training module is also, available for every staff that works within maternity and neonatal staff to also complete. And clinical training aids was also, given out to many trusts to support them in terms of the, having manichees that represent different ethnic groups. Next slide, please. I'm just going to narrow your focus on the middle of the slides. So these slides really clearly state, set out the interventions to address inequalities. We are doing so much, but there's so much to be done, more to be done based on the challenges that we are currently facing. So on the left-hand side is the generic interventions that we are currently doing, and many of you on the call will be familiar with that in terms of the maternity care bundles, Saving Babies Life care bundles that have been rolled out. And on the right-hand side are the challenges of what we are currently going through. So let me bring your focus onto the center, which is the equity-specific interventions. I've already mentioned the workforce interventions that we are currently doing in terms of the perinatal equity and anti-discriminatory program, which we are hoping that this will address the way staffs hear and listen to women from diverse communities. And also, most importantly, to ensure the workforce anti-racism program is also to improve representation of ethnic minority in senior leadership, and the removing racial bias from our clinical education is absolutely key important. So we're also looking at the model of care, enhanced continuity of care, which many of you will be very familiar with, especially the most deprived areas, which provides action to support those women that most actually required it. And the genetic risk and equity project, which was to support that Pakistani community, has also been much effective and may actually be the one that contributed to the decrease in data that I just shared previously. And consistent clinical care, the triage that I mentioned. So these are really specific interventions and many more that we're currently doing, to address that inequalities. Next slide, please.
Wendy, can I just one more minute, please, so we can go.
Okay. Thank you very much. I will speed through this. I think I'm coming to the end of it. So I will quickly just mention about preconception health to promote equity. I think this is absolutely important. Looking at the whole population, holistically in terms of, what are the challenges of different, community groups. once a woman arrives at maternity services, the scope to improve her and her family's health is absolutely limited. So the point is to get them even before they come into maternity to ensure that they have the right support. Next slide, please. And I believe this is my last slide. So in summary, this slide just really, informs us of everything that I've said in terms of the government's commitments to set a target to address and to close the Black and Asian maternal mortality gap. The Health and Social Select Committee's Black Health Maternal Report, in terms of what their recommendations have been, is what we are also working through. Again, the Secretary of State, in terms of their concerns and their commitment in addressing health inequality within maternity, and the NHSE and CNO requests to ensure that they make this as a priority and maternity is not being left in isolation. And the work that we're doing across the system, in the local maternity and neonatal system, and most importantly, the workforce interventions to support the workforce to provide culturally sensitive care. So thank you.
Brilliant. Thank you so much, Wendy. Really good to see some of those graphs and to see where the spikes were, but to see that it's actually decreasing, that gap is decreasing. So some of that work is actually changing things, and that's brilliant to see. I can see in the Q&A there's no specific questions for Wendy and George, so I'd really like to bring in all of the panel members if we can. So we've got members of our service user network who are joining us today, as well as Nicky Vousden from MBRRACE. Maybe we can stop sharing the screen so we can see everyone's faces. Thanks, Catherine. Okay, so to bring everyone in and to hear from our service user network members, I wondered if I could perhaps go to our SUN members first and ask about your experiences. And do you feel like the women and families are treated the same in maternity care, or did you notice any differences? So perhaps we could start with Naomi. You've just stood out to me there for a moment. Naomi, can I bring you in?
Yeah, is this the first question?
I'm asking from your experience, do you feel all women are treated the same in maternity care?
No, not at all, no. For me personally, it was with my mental health and my history. I felt like I was discriminated against based on that. And I was 23 when I was pregnant with my daughter, but I looked a lot younger due to my history with eating disorders, and I was treated as that I was really naive and really silly, and that I just wasn't I don't know, I felt like they just thought I was going to fail as a mum, and there was no real support there, and they were just, it was like before I had my daughter and afterwards, it just felt like there was no support. They were just kind of waiting for me to fail, and that had a really negative effect on me.
Of course, and a lot lasting impact as well, I imagine.
Yes, it did, yeah. Because even then, throughout that time when I was struggling with my mental health, I felt like I couldn't reach out for support because of the way I'd been treated at the beginning, and I felt like if I said I was struggling, then they were going to take my daughter away from me, because I felt like they already thought I was going to fail. And I've spoken to other mums since, and that's not the only, I'm not the only one that's felt like that. And it's really upsetting, because you're taught that you should be able to go out and seek support, but actually you're told to just kind of deal with it on your own, because then you're at risk of losing your child.
Thanks for sharing that. Riham.
Thank you, Kim, and thank you, Naomi, for sharing this. I just wanted to add one more thing about being treated equally on maternity ward. It's, I think, one of the main issues that plays a big role in this is the language barrier, to be honest with you. If English is not your first language, again, you will not be able to express yourself, say your wishes, ask a nurse to come and help you. If you have valid questions that you want to answer to the professionals, you wouldn't be able to. And preparing for an interpreter to come and be there for you might take hours, if not days. So the questions are gone, and I think this is something very difficult to be added. When I came here 20 years ago, and I have 4 children, so I've been admitted to the maternity 4 times, and at the beginning my English wasn't good, so if I wanted to ask a question I would struggle somebody to help me, So interpreters are very important, translators.
So what do you think about some of the work package plans that Wendy showed us just now about addressing some of these issues? What do you think? Do you think that could be helpful to bring those where they're putting training in place, making sure there's interpreters available?
Definitely, 100%. And I want to thank Wendy for this lovely presentation that gives hope and gives reality as well. So it gives you the reality, yet on the other side, it gives you hope that things hopefully in the very near future will go to the right direction.
Thank you, Riham.
Thank
Meg,
you.
I want to bring you in because I know you do a lot of work up north with a big community as a birth worker. What do you hear when you're working with mums and families?
So yes, I do work with a lot of families, and what strikes me is that access arrangements are always driven by disclosure by the service user, whether that is a disability access arrangement or whether it is something like language, like Riham said. And I have noticed in other sectors, such as recruitment, that question of if you need any accommodations being made to make the process accessible to you is asked at every single touch point, and that doesn't seem to be the case in healthcare. And it seems like such a very simple thing that we could do to change people's experiences. Excuse me. I do think that there is systemic bias in the design of services, and I think if we increase the amount of patient participation within service design, that would go some way to helping to eliminate that. I think we all need to hold on to the concept that if services are designed and implemented in a way that is inherently accessible to most people, whether there is disabilities, whether it is language barriers, whether it is their race and ethnicity, then that benefits every single person, whether or not they are impacted by those specific barriers. I also think that we need to address something that might be the elephant in the room, and it is really good to see Wendy's presentation. It was fabulous. Thank you, Wendy. We have seen all of these projects being talked about in the past, and they are kind of iterations of previous work, and we need to make sure that the work is actually embedded into systems and we don't shy away from the words that we use and soften it out of any sort of fear of making it awkward for employees. We need to use the word racism, we need to use the word misogyny, because if we don't use those and we don't use those in the context of if people receive racist care, they may die. And that is, I'm sorry to be blunt, that is the kind of the baseline that we're looking at. Then we need to make sure that people understand that when they are doing their cultural competency training, and make sure that point isn't lost through any softening of that sort of training. I know it is really difficult to provide that sort of training to employees and not make them feel attacked, and I don't in any way want to make midwives and maternity staff feel like they are to blame for system problems, but we do need to make sure that we are kind of working in tandem there.
Thank you, Meg. Really well said. Al, I want to bring you in. I know that we can't see you, but as our dad representative, I wondered, you made a point as well in some of our emails about making sure we use that word racism. What do you think the impact is of not using the word racism, saying discrimination or bias?
I think we're watering down words. I think it's very interesting to note that when I read kind of Wendy's plan, I thought to myself, this is a lifetime plan almost. We're not going to see significant changes unless we actually don't water down the language, as what Meg said. I think when you send out a plan like this, for example, Wendy, to NHS organisations, they interpret it in their own type of way. They change it. The words do get changed and everything gets watered down. And I think unless the plan goes in the exact way that you've actually spoken about, it won't actually make any tangible change. And the reason why I say that is simply because I think sometimes it's very easy to say that, racism is over there, othering is over there. But people are more scared of being spoken to or being told that they're a racist than actually being racist themselves. And I think when you're then noticing that disparity of care, so my wife is a woman of colour, Muslim, so she wears the scarf. So we had anti-Muslim hate as well as the kind of language barrier. And I was very lucky in that I'm white passing, and I did not accept any of the things that the maternity staff said to me. I ended up getting second opinions. I made sure that complaints were logged at each point. So the matron was constantly coming into our room. So there was a level of fear that I had to use to make sure that my wife did not become a statistic on Wendy's poster. It was really difficult to actually tell people what their jobs were when actually they should have known what their jobs were, and how it was that they were best to actually be able to be more culturally competent. Because in this country, unfortunately, the level of racial literacy and cultural competency is very low. They're okay to eat other people's dishes and things like that, but actually to go and do some of that work towards understanding those people is just not there. There doesn't seem to be an appetite at all. So I think there needs to be more understanding around actually people and their differences, and more compassionate care. I hear the word compassion being bandied about like it's just something that looks nice on a piece of paper, and it does look lovely on a piece of paper. But where are our staff actually practicing that compassion? What is compassion to that person? If that was your child on the other end of this service and you were treating them, how would you treat them versus how you actually treat your current patient?
Thank you, Al. Just a little bit muffled when you speak. So next time, just maybe step away from the microphone a little. But thank you. I did hear that about compassionate care. I wondered, Nicky, if we could bring you in and talk about MBRRACE. And obviously, Wendy brought up some MBRRACE data there. Can you tell us a little bit more what that what the impact MBRRACE is making when we're looking at inequalities?
Yeah, sure. And thank you for having me here today. And thank you, Wendy, for shining a light on the challenges and talking us through some of the fantastic work that's going on as well. Always appreciate hearing your wise words on it. So MBRRACE, as Wendy mentioned, has been reporting on inequalities in maternal health and making them visible, really, since its inception, but strategically reporting on differences by ethnicity and by women who live in the most deprived areas for over a decade. And what's important is it is that figure, that graph that Wendy showed, but it's also about translating that message into very clear visuals, very clear messages, so that the public, every policymaker, every stakeholder can understand what those challenges are. And that's a really critical thing, because that's how we help to drive change. So Wendy mentioned 5 Times More, for example, which are a fantastic organisation whose name is taken from that inequalities finding. It takes those kind of advocacy, education, powerhouse groups to really shout about these problems and get the buy-in from policymakers and make it something that can't be ignored. So it's about that whole system of different organisations all being able to have the same message to drive forward change. And I think that's something that's really powerful from MBRRACE, is that raising awareness. The second thing that's a really big part of our work is understanding the care that women receive in detail. So doing deep dives by different groups. So for example, recently we've reported on the care of women who are recent migrants, or also recently looked at the care of women who had their children taken into care or children's social care involvement prior to death. And having those deep dive looks enable us to have really rich understanding of what's underpinning those outcomes, and enable us to make recommendations around what should be changed to improve care. So it's a combination of the numbers, but also telling the stories of these women so that they can be really widely heard. And the last thing is, or the last 2 things I wanted to say was about, one of them is research, really shining the light on what we don't know. We don't have good evidence, or we didn't have good evidence, it's getting less, but of how to reduce inequalities. What are the services that make a difference? How do we deliver the right cultural competency or compassionate care training to midwives? They're all really big questions, and it takes time and effort to be able to answer those. So shining a light on those questions and helping to encourage more money into research, like that NIHR research money that Wendy mentioned, is really important. And then lastly, monitoring progress, being able to share what's happening over time. And that was really critical during the COVID period, but remains as critical, so we can say, are things getting better or worse over time? And we can keep on applying that pressure.
And it's really interesting because when you think about inequalities, it's such a broad spectrum. You know, Wendy's focused on ethnicity and race, but we've also, Naomi's just mentioned mental health, and we heard from Sarah earlier talking about multiples. And so we've got to look at so many different things. And I know MBRRACE reports on a lot of it, and then trying to like focus in on a few things, few topics to improve that area every time.
Yeah, exactly. And those topics, they're driven by our lived experience members and by our charity stakeholder groups, actually. So we have two lived experience long-term key members who attend the monthly meetings from SANS and from Maternity Voices Partnerships. And then they have a stakeholder group every year with much wider representation. So there was over 41 different individuals from 30 charities, and they have early insights into the report findings and are able to help us understand, synthesize those, translate them in a way that makes sense, and also feed into what we might want to do those morbidity inquiries on next year.
I'd like to ask George about NMPA, but I'll come back because I can see some questions showing up now in the Q&A. Lacey, can you pull out a couple of questions for us, please?
I can. An interesting question that's come in from Stephen, it's on the back of the expected Donna Ockenden review tomorrow, is around audit. I think that's quite relevant for all of us today in particular, which is what's the panel's views on how effective clinical audit currently is, and or maybe the scope for it in the future, at identifying what he calls substandard care in maternity, or perhaps if we turn it on its head, how we might use audit to improve care.
So actually, George, I wonder if you know of some local examples of people using the NMPA data to do some good QI locally.
Yeah, no problem. That's a tricky question, but I think certainly in terms of QI work using clinical audit, I think it is really impactful to see the work that is done when that data are used. So for every report that we produce, along with other national audits, we do an outlier process. So we have some measures which we deem as outliers, and we will look at the services that have particularly notable differences in care to the average trust. And we contact those trusts, we send them a letter, and they will write back with their response. And that can be a really valuable process. And we publish all of these responses on our website. We'll be doing so again in August when our new report's published. And how thoroughly some of those trusts go through and come up with plans on how they have used that data to then turn their services around, address those issues, and really tackle them head on is something that's really valuable to see. So you can just see directly how the data from clinical audit is used by these services. They see how they're an outlier, and then they use that data to really, address those issues, and that's really powerful to see. But it's not just the negative outliers. We're always really keen to think of trusts who are doing it really well as well. Like, it's important not to forget that and find out the stories of those trusts and services that are doing really well, whether it's in care generally, whether it's addressing inequalities, and trying to really share those stories. We try and have those examples on our website, share those stories so that others can learn from them, and in as many forums as possible. It's a really important thing to do. But to try and address Stephen's question slightly more directly, I do think clinical audits need to work hand in hand with experience as well. I think there's work being done on I think it's called a patient, we wouldn't use that language, but a patient reported experience measure, so that we can get data on that as well. It's not just the qualitative data that we focus on in our clinical audit, but also getting that the quantitative data, but also getting that qualitative data from those who experience the care as well is vital.
Thanks, George. And actually, I've got my colleague Tina Strack is here, and she is an associate director at HQIP and does manage a lot of our maternity programs. Tina.
I'll just speak really quickly. Stephen, I think that's an excellent question. And I think you're absolutely right. I think a couple of thoughts I've had is, and this actually came out from the first Ockenden report, didn't it? That I think up until now, we've had these great bits of information in their own little silos. And there is something about, we've got to put the them all together because it gives us a full picture of what's going on, because you'll have patient safety data as well as some MBRRACE data as well as data from NMPA. So I mean, George was touching on this as well. I think it's the putting the pieces of data together. MBRRACE in particular, you've done a piece of work, haven't you, about maybe ways that we can try to flag, ooh, there could be a problem here. Our data is showing us that there could be something here. And the other thing I'd say, probably a little bit with I'm also a lead governor. With my lead governor hat on, is kind of that internal clinical governance, making sure that the right people internally are seeing this information and using it and asking questions. But it's a really tricky one. Thanks, Kim.
Thanks, Tina. Well, I think bringing in that thought as well about making sure we're measuring the experience into these clinical audit programs and, MBRRACE as well. I wonder if our service user network members would like to talk about how they think women and families should be more involved in these programs. Do you want to go first, Naomi?
Yeah, that's fine. Women and their families must be meaningfully involved in the design and development of these programs. Their insights should actively inform improvement efforts, and they should be supported to share their experiences in ways that ensure they feel heard, respected, and valued. A co-production approach developed in genuine partnership with families is essential to creating services that are responsive, inclusive, and effective. The voices of those with lived experience are not optional. They are a vital source of insight and should be recognised as central to shaping meaningful and lasting change.
I think that's a great answer. Thank you, Naomi. Meg?
Completely agree with Naomi. I preface this with, in my opinion, I think that there shouldn't be any public sector service or programme that isn't co-produced at every stage of the process. And in an ideal world, service users would be involved at every step. We bring context to data, and knowing that there has been public involvement in data collection, analysis and implementation of the results does give an inherent value of trustworthiness to it and how it's used. But we also know that the real value of data isn't just answering the questions that we already have, but also providing insights into questions that we didn't realise exist. And I think as soon as we have a larger diversity of eyes on that you do get through service user involvement, then we start to ask the right questions and be able to move in the right way. I think it's also very important that we don't just look at safety through a narrow lens. When we're talking about safety, if we just look on the very worst outcomes, then we also miss psychological safety and patient experience, and they need to be built into the things that we are looking at, monitoring, analysing and collecting data on. We also risk overlooking sort of lower level harm if we're focused solely on morbidity and mortality. So we do need to make sure that we are having a wide view when we are collecting data and making sure that we do have a diverse range of views when we are doing this work, and also involving service users at the very onset of any sort of programme of work, because it's through that where we really get the insightful questions that are being asked.
Thank you, Meg. Really good points. Riham, what do you think from a women's perspective, from families' perspectives, audit and improvement programs should be focusing on?
I think the main thing we should focus on, from my perspective, is the co-production. Involve the woman in every step along the way. Don't just fill them out with a questionnaire, ask them from the very beginning, co-produce with them, listen to everything they ask, take it into consideration, because this is lived experience. And what more can you value than a lived experience? From the very early stages of any audit you want to start, take into consideration every voice. And we should be very thankful to whoever woman that wants to collaborate and give their voices and give their give their views or give their comments, because some just say, I don't want to participate. So let's give value to the voices that we hear, put it into consideration, co-produce with them, and make it something essential. Thank you.
Thank you, Riham. Sarah, as one of those women who is very, very involved in an audit, how do you feel? How does it impact you from doing this work?
Well, it's I find it kind of grounding and rewarding to put my lived experience to good use. And I agree with everyone about the need for wide and diverse patient and public involvement at so many levels. And I also wanted to stress like the benefits that can be brought from working with third sector and community organisations as well. I touched a little bit upon that in my presentation. So that should be seen as like an important PPI strategy as well. So for example, I liked how Nicola mentioned like deep dives, and we talked about how we focus on a particular inequality to like deepen like action and address of those issues. So I think stakeholder mapping can play a really important role in that. Exactly who do you want to have represented, and including which third sector and community organisations, because they can help highlight inequalities and gaps as well as bring important solutions. But I'd also like to stress that that is something that needs budgeting for in terms of time and resources, including money. You know, third sector organisations are on their knees, so it's also something that we shouldn't take for granted.
No, but really good point. And there are a lot of maternity organisations out there, actually, aren't there? And focusing on different specific areas, like Twins Trust that you mentioned, Sarah. It's 3 o'clock, and I could ask another million questions, but I'm really sorry we have to end the session now. So I want to thank our speakers so much, our speakers and panel members. You've all done a great job. I really appreciate you all being here today. So tomorrow, be aware, we have got Jim Mackey coming at 10 o'clock. So please look at our website for information on how to register and join the sessions of the rest of the week. We have got this QR code here that you need to scan to give your feedback. We welcome any comments. I don't know if anything else I need to add, Lacia?
No, I think you've pretty much covered it. Just thank you to everyone. It's been a wonderful experience. Do have a look at our website and find out everything you need to know about what's coming up.
Oh, okay, I thought it was a final. Okay, brilliant. Thank you all so much. Have wonderful afternoons. Go and keep cool. I might have a cold shower. It's so hot here. Okay, good night. Goodbye. Thank you.